So good evening, everyone. Welcome once again to the Africa Healthcare Network weekly webinars. And my name is Dr. Amar Swali from Dar es Salaam, Tanzania. I'm the consultant physician and nephrologist working with Sri Hindu Mandal Hospital based in Dar es Salaam. I have the pleasure of introducing one of our most active presenters since the inception of the Fireside chat series in late 2020, and it's none other than Dr. Santosh Varughese. He really needs no introduction. This is his fourth presentation with us. He had earlier given us 2 talks on renal cell carcinoma and neurotherapies in glomerulonephritis, and he's back with us today to talk to us about the essentials of slow continuous renal replacement therapies. Dr. Santosh, he is the professor of nephrology and head of department of nephrology at the Christian Medical College and Hospital in Vellore, India, and he also has a fellowship in nephrology and transplantation from the University of Toronto in Toronto, Canada. So Dr. Santosh, without taking much more time, I would like to welcome you for your presentation. Thank you so much for being with us once again.
Thank you, and as always, it's speaking to this forum is a bit of homecoming. You always see so many of your friends and catch up, although not being able to do so in person for a long time owing to various widespread issues because of COVID. But it's such a joy to come back and come for this meeting, and it's a pleasure. The pleasure is all mine, and no worries, nowhere near my bedtime, and I'm happy to talk about this topic. And I'll share my slides now. I hope it's visible now. So talking about the CRRT today. Uh, uh, I didn't want to mix up CRRT and SLED because the topics are going to be considerably different. If you all have not discussed SLED in a recent bit, I'm happy to talk about SLED another day, event soon. But that's entirely if there's any discussion required. I must say also as a disclaimer that my SLED knowledge isn't like some centers in the West, especially where they do a large volumes of SLED. Sorry, CRRT. CRRT is what we learned during our time in Toronto. Then we modified a bit, adapted, and we are practicing in Vellore. So, and a lot of it is what we learned while doing. So, without much ado, I'll start now. And
thank you.
So we'll begin with a case, a typical patient that we would see, 75-year-old gentleman who's diabetic and hypertensive, who comes with fever and oligoanuria, anuric for 6 hours with decreased level of consciousness for 2 hours, hypotensive, tachycardic, hypoxic, and with severe renal failure. K is 5.8 and bicarb is low, and the white cell count is 27,000 with 95% polymorphs with left shift on the smear. So we are called on consult, and what should we do? So this obviously a case of sepsis with septic shock with acute kidney injury and an impending, or if not really occurring, a multi-organ failure. So this presentation will talk about the essentials of CRRT and how to write prescriptions for CRRT for AKI. I must confess that some of this is derived and not really from a book. And the last is something which we've done a little bit of in a couple of cases of connecting CRRT with ECMO circuit, and we discuss among ourselves, so I'll talk about that as well. So in sepsis and multi-organ failure, we have a aberrant immune response and cytokines going haywire. We have what we were created for good cytokines actually going awry, and we have a cascade of events that leads to multi-organ failure and death. So when we were being trained in our nephrology hosting a nephrology training in 4, we were told that AKI is a reversible condition and not much of a worry. We might have some tubular dysfunction that's left over, but by and large, the kidney function returns normal. And now we do know that it's not true, and the literature now says that um, depending on how sick the patient is, as much as 2/3 of our patients uh, could have a problem, and with some degree of dysfunction, and the mortality is high in these patients, that we knew. And of the ICU survivors, quarter of them could end up on dialysis within 3 years. So this is news which has shaken the nephrology world, and we started paying more attention to follow up of these patients. But that's a different thought. So coming to the KDIGO guidelines, which we follow, the KDIGO guidelines suggest that better than standard intermittent hemodialysis or intermittent renal replacement therapy, which includes SLED, the guideline suggests using CRRT. And CRRT is preferable for patients with acute brain injury or other causes of intracranial pressure or generalized brain edema. Before I go on to the topic, I just want to say there is one study which measured intracranial pressures in patients who had chronic kidney disease and were on dialysis, and who had raised intracranial pressures, and they were on intraventricular drains. So this ingenious study actually measured the intracranial pressures for these patients, and in two groups randomized them to receive either SLED or CRRT, and found that the intracerebral pressures are exactly the same. So what we believe today as CRRT being better for patients with acute brain injury and brain edema actually may not be the truth, but we need more literature on it. So just for whatever it's worth, I just thought I'd throw that in. So when the ICU calls us for consult, we know that they expect us to deliver with some form of dialysis, extracorporeal therapy, euvolemia, calcium as a base disturbances. And the study came in where they talked about removing toxins from circulation, which I'll deal with in the next few slides from now. And they want to support the body, and we want the kidney function to recover quickly with good survival and free of major adverse effects. Obviously, not all of these do happen, but by and large, if we can cause the patient to survive and come out of this current illness, we've achieved our target. So there are many different RRT modalities, and each of them have got their advantages and potential limitations. And all of them, apart from petrol dialysis, require a large bore central vein cannulation, obviously, for extracorporeal therapy with a circuit. So the principles are similar to what we do know in hemodialysis, so I won't repeat them here. Ultrafiltration as well as diffusion. In this CRRT, there is the additional thing called solvent drag or convection, in which there's a large volume of water removed, exactly as we would do in ultrafiltration. But this large volume would drag with it solutes, which is limited only by the membrane pore size. And you have both large and small molecules removed roughly equally, and the limitation is only the pore size. So this is pictorially what we do know hemodialysis being by diffusion, and against the concentration gradient, and the dialysate taking away the toxins, and hemofiltration, which is under pressure. There is a transmission for drag of toxins along with water, and obviously when you have large volumes of water, you need to replace it. So this is a table which shows the different renal replacement therapies: intermittent, which includes intermittent hemodialysis, which we use most commonly, and the SLED, and the continuous therapy, where peritoneal dialysis is also a continuous therapy, and the others which we are going to talk about today. So the invention of continuous renal replacement therapy was in order to mimic what God has created us with. And the patients who are unstable and who are severely ill in the intensive care, this modality would be gentler for them to follow, and it's not a single therapy; it's a family of different modalities, and the nomenclature depends on the access and the principles used. Initially, incidentally, the first continuous RRT modality used was a continuous arteriovenous fistula in 1977 in 88 person who was unsuitable for peritoneal dialysis or intermittent hemodialysis. So that is the inception of therapy. In order of increasing complexity, we have the slow continuous ultrafiltration, which is just fluid, and the hemofiltration, hemodialysis, and the hemodiafiltration, which combines both hemodialysis as well as hemofiltration. The arteriovenous hemofiltration hemodialysis has largely been given up now because the arterial pump is usually compromised by the blood pressure, which is often very low in these patients. So the continuous venous hemofiltration, as I said, is similar to the SCUF for the slow continuous ultrafiltration. That's only ultrafiltration, but you have a large volume of fluid that's removed as compared to in SCUF where you remove very small volumes, and it removes a large amount of solutes using obviously high flux membranes. And because we're removing fluid at this weight, 1 to 2 liters, you need large volumes of replacement fluid, and the solid clearance, as I said, were the same. And the determinants is mostly the rate of ultrafiltration and the other things which we know of. In the blood flow rate is 200 to 300 ml per minute, although we can lower it down to as low as 100 ml. There's a concept called filtration fraction, which we keep between 10 to 20%. I'll come to the calculation of filtration fraction, and that is useful. That calculation is useful to when we want to up the ultrafiltration, the blood pressures are constant, and to determine what is the maximum dose, maximum amount of fluid we can remove. And CRRT dose is determined by the replacement volume based and the fluid removal over the entire session. The fluid can be given pre or post filter. It's a picture, if we know, I'm sure we know. Fluid goes from the patient to a pump, and the convection gradient and the effluent removes the toxins, and we give replacement fluid, which you can give either after the filter or before the filter. Now, there's a question: should we give the fluid before or after the filter? It's a little controversial as to which is better, because the question is which is better. So the books and the articles aren't very clear in saying which is better, but what we do know from the literature is this: that if we give it pre-filter, the toxins diffuse out of the cells, mostly the RBCs, and the clearance actually increases. And because of the large amount of fluid we're giving, the circuit is less likely to clot, less anticoagulation needs to be given, especially if the patient is already quite coagulopathic. Post-filter, we can manage with compromising on the volume that we give. So if you want to save money, post-filter is better, but pre-filter may be giving a better clearance. So for whatever it's worth, I think the jury is out on which is the best way to follow, but for whatever it's worth, I put both together up here. And we can also do continuous veno-venous hemodialysis, which is without filtration, in which is exactly like the conventional hemodialysis, except that the rate of the dialysate, what we call QD, the dialysate flow rate, is very slow. It's 1 to 2.5 liters per hour, as opposed to 500 to 800 ml per minute in our conventional hemodialysis. And the solid removal is by large pore size, high flux hemodialysis cartridges by diffusion. And the dialysate flow rate is slower than the very slow compared to the blood flow rate, unlike hemodialysis where the dialysate flow is twice as high. And this slow flow allows the small solids to infiltrate completely, and the dialysate flow rate leads to the clearances, is what we use for calculating the clearance. And some, because we do ultrafiltration for volume, there's some small amount of convective clearances at high rates of ultrafiltration, but nowhere to the degree that we get in hemofiltration. So this is the circuit for the continuous veno-venous hemodialysis, where there is no replacement fluid. The dialysate flows concurrent to the blood flow in the dialysis compartment, the dialyzer, and is returned to the patient. The most common method used worldwide now is a combination of the hemofiltration as well as hemodialysis, what is now called continuous veno-venous hemodiafiltration, where we combine the benefit of the convective solid removal as well as the diffusive benefit of doing a hemodialysis. And because this is happening so gently, there's not much hemodynamic compromise. And when we say CRRT today, worldwide people understand it to mean CVVHDF rather than CVVH. Historically, CVVH came first, and therefore it used to be synonymous with CRRT. But now, when we say CRRT, it means CVHDF in the world over. It is likely that using hemofiltration and hemodiafiltration are likely better than hemodialysis, but there isn't any data to show this. And between filtration and diafiltration, the choice is based on institutional preference. Most of North America uses hemodiafiltration. Most of Europe, I understand, uses hemofiltration. So it's based on institutional preference. It's also important to remember that the intravenous replacement fluid concept came from CVVH, that is the hemofiltration, and not from hemodiafiltration. So this is a picture of the hemodiafiltration, where you've got dialysis happening across the membrane, and you also got large amount of fluid and toxins and solids removed by ultrafiltration, and you've got replacement fluid, which you can give either before or after the dialyzer. Okay, now coming back to CRRT, we know it's gradual, so there's no hypotension, and you can give drugs and blood and FFPs, and you can even do parenteral nutrition, or what we call interdialytic parenteral nutrition, with no risk of worsening of fluid overload, because you can actually remove the fluid. Toxin removal has been a very controversial topic, and although they say that CRRT makes the toxin removal complete and aids the recovery, we're not sure, because the toxins slowly diffuse back from the tissue in circulation, as I show in a few future slides. The removal is not much. But the advantage of doing ongoing RRT is that whatever comes back into circulation, you're able to remove. And in septic shock and multi-organ failure, is large volume molecular weight solid removal useful? Some people do believe so. We're not very sure. The trials, initial observation trials, and this is where they really hit off, saying that CRRT was superior to intermediate hemodialysis in ICU patients. But there were 4 RCTs around the turn of the century, early 2000s, which showed no clear mortality. And the largest was the Hemodialysis trial, which had 360 patients, which showed equal survival in both groups and no difference in hypotensive episodes. And you must remember that this is not with SLED, it was with intermittent hemodialysis. So even in that group, they found no superiority and no difference in the hypotensive episodes. And 2 meta-analysis and a Cochrane systematic review later, they are down to conclude that there is no demonstrable superiority of CRRT. And the new AKI trials, which came about 10 years ago now, have assumed that CRRT and SLED were equivalent. So when they divided the groups, they put CRRT and SLED in the same group as against intermittent hemodialysis. Now, the hemodynamic tolerance is the most important advantage of CRRT because it's slow ultrafiltration, very gentle removal, and allows the control of volume status easier, allows medication, as I said, nutrition, better control of acidemia and electrolytes without fluctuation, that like the patient isn't uh, 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 near normal during the session of renal replacement therapy like SLED or hemodialysis, and abnormal uh, metabolic milieu when the therapy is stopped. We allow it to continuously be normal, and the fewer episodes of reduced renal blood flow and renal ischemia and more rapid recovery has been shown in some studies. Dr. Mehta's study in which he randomized patients into either intermittent hemodialysis or CRRT. The study was a negative study in which it did not show superiority of CRRT, but what they did show is that the CRRT patients survived were more likely to show renal recovery than those who did not, with those who were given intermittent hemodialysis. Okay, so the other point which we started off by saying about intracranial pressure, because no rapid solute shifts are there, there should be no raised intracranial pressure. Take it with a pinch of salt, because this is the theoretical aspect of it, but when they measured it, they did not find a difference. And the cumulative tox solute removal, because you're giving it 24 hours, uh, over time, it is actually greater than with hemodialysis. And the large volume of distribution toxins are able to be, with slow back diffusion, are also able to be removed. The controversy, as I said earlier, is about whether it's useful for intermittent cytokine removal, which is our problem in patients with sepsis. So there's a hypothesis called peak concentration hypothesis, in which the mediators rise and fall, the toxin, the pro-inflammatory and anti-inflammatory mediators rise and fall, and the peaks are they can happen in sequence or in parallel, and the CRRT controls the peaks and is hypothesized to decrease imbalance and to restore immunohomeostasis. But this is largely unproven and is only a theoretical construct at the moment. For example, they have actually shown that many middle molecules like TNF alpha have been removed on CRRT, and that is a big thing that the companies propagated, that actually remove TNF alpha and other cytokines and reduce the inflammation. You can remove and absorb. And what actually was found is that the removal or elimination happens maximally and often only during the first hour of the new filter application, or when you're starting this CRRT. And the pro-inflammatory cytokines and the anti-inflammatory cytokines, which we want in anti-inflammatory ones, we don't want the pro-inflammatory ones, but they're both removed equally. The equivalent removal may mean that actually you're removing even the good things and it may not do benefit. The most important one, of course, is that the cytokine removal capacity does not match production in sepsis. So there's been some elegant data which shown that the plasma concentrations of the pro-inflammatory TNF alpha does not change despite giving 72 hours of CRRT, meaning that the removal is very, very, very small in comparison to the large amount of production. It's like trying to empty the ocean using a teaspoon. So I'm sure that allegory is enough to show that this actually may not be as effective as initially what people felt. The disadvantages are that there is a requirement of an axis, and already these patients who are on multiple tubes, you need to put one more, and there will be clotting of the axis and the filter, so you need to give anticoagulation. That is a problem, and this can cause life-threatening bleeding as well, and dialyzers clot if you don't give, and you need to give large volumes of replacement fluid, which is expensive. Now, just talking about the anticoagulation before we go on to the dose. Unpatched heparin is a problem if you use it. If you don't use it, the filter will clot. It causes bleeding in about half the patients and hit in about 5%. The good thing is you can use protamine to reverse it, but there's some anaphylaxis has also been reported. Low molecular weight heparin, longer half-life, and protamine is ineffective for reversal, and other things have been mentioned but not routinely used. So these are pictures which show that there's a dense fibrin network with large amounts of aggregated erythrocytes and the pseudomembrane formation. And this is a magnified view of these patients when unfractionated heparin is used. A low molecular weight heparin usage shows a stronger fibrin network but much fewer RBCs. And we use citrate. This is one of the most popular ways of use anticoagulation for CRRT, regional anticoagulation. Only a few cells adherent to the surface and there's no thrombus, and therefore the circuits could be used for much longer without changing. The filter need not be changed for a long time, as a major advantage of using citrate. So citrate chelates the ionized calcium, and before returning the blood, we need to give back IV calcium. And if a triple lumen dialysis catheter is used, the third lumen is not used because you'll have recirculation and you have inaccurate calcium values, less effective renal anticoagulation. Therefore, you need to have a separate line giving the calcium infusion back. Now, the question is, why do we consider regional anticoagulation with citrate? And if this paper is a very good paper, came out in 2015, in which they looked at the survival comparing citrate and heparin, and this showed that the filter can be used for much longer if you use a citrate-based anticoagulation as opposed to heparin-based anticoagulation. There are some important contraindications, especially liver disease or active hepatitis. That is the most important consideration, and because your dose of lactic acid with really high lactate, if there's liver dysfunction again. So the liver is the biggest culprit, or if the patient is on ECMO, also they suggest that don't use citrate, use heparin. So in scenarios where you have a problem, or if you're using large amounts of blood products, which also may contribute citrate, you suggest that we be careful when using citrate. So coming back to what we were saying, the RCTs comparing heparin and citrate showed a clear superiority with the increased filter life, decreased transmission, decreased risk of bleeding. But the fluid is expensive. Now that brings us to the topic of the fluid. The dialysate and replacement fluid are similar to plasma in terms of the alkaline composition, give or take a few parameters which may be up and down. In those areas where, and in earlier times where commercial fluid is not easily available, we actually have made our own CRRT fluid using PD fluid, 1.5% PD fluid with adding calcium chloride and so on. I'm not sure if Dr. Lloyd sir had used this ever. I still remember we had a demo machine which we constructed CRRT replacement fluid using peripheral dialysis fluid. But we've got now commercially available solutions, less dextrose, and buffers are usually lactate, rarely acetate, and the problem in sedation with failure, severe lactic acidosis. The initial bicarbonate-based fluids are unstable. Now there are more commercially available stable fluids are available, and better effects in the body, less hypertension, less cardiovascular effects, and correction of acidosis being faster. Now coming to the most important part of the presentation, and for anyone who is writing CRRT orders, is dosing. Now, what dose has to be given for these patients has been a subject of great discussion and controversy. The ADQI came up with recommendations saying we must give them the dose in acute kidney injury patients equivalent to that which we would give for CKD stage 5D, that is patients on ESRD on hemodialysis. That although is there, but people generally say that correction of the acidosis, hyperkalemia, fluid overload in a patient, an acute kidney injury patient with anuric, may be far more important than dose per se, and they use kd/v only for intermittent hemodialysis and the SLED and not for CRRT. Now coming back to the doses that we do use for CRRT, there were 3 trials at the turn of the new century, in which the first one showed that the dose of at least 35 ml per kilogram, this is in the early 2000s, was better than 20 ml per kilogram for survival in the ICU. The other thing, which was daily intermittent hemodialysis, was superior to conventional hemodialysis prescription, in which the nephrologist would see the patient every day and decide, should we give dialysis based on the patient's fluid status and electrolyte imbalance, or should we just give daily 6 days a week until the patient's kidney function improves. So this is a study which came out in the, I believe it was the New England Journal of Medicine in the year 2001 or 2. I'm not very certain which year it was, but it showed that daily intermittent hemodialysis was better than the nephrologist decided should we give dialysis or not. So they suggested patients could be on autopilot until the kidney recovers. So very interesting statement. The other thing was increasing the RRT dose by adding dialysis to hemofiltration. That is, changing from CVVH to CVVHDF showed better survival. So 3 trials at the turn of the new century, early 2000s, showed these things. However, the first point of the CVH dose of 35 ml being superior to 20 ml was changed when the pendulum swung in the opposite direction. When there were 2 studies, I'm sure which we know, which came out in the late 2000s, the first decade of this century, in which the pendulum swung in the opposite direction, and they said that the ATN study and the renal study, which compared 40 versus 25 and 35 versus 20, found that actually there was no benefit of giving a higher dose CRRT. And now there are 2 systematic reviews and meta-analysis after these 2 RCCs came out, showing there is no benefit of increasing the RRT dose to reduce mortality or hasten recovery of renal function. So right now, the dosage that we are currently advised to use is 20 to 25 ml per kilogram per hour. This is the CRRT dose. So this magic number is what we study for the exams. This is a table comparing the different modalities. I think I'm running out of time, so I won't I won't go through this list. Now coming to the hemodiafiltration, the dialyzer, it must be a high flux, high permeability and biocompatible, and various membranes are used, and there's no data suggesting that one type of membrane is better. There is some theoretical benefit of using a polyacrylonitrile membrane, which does some adsorption. So the company will have you believe that use this because you'll have some cytokine removal, better cytokine removal by adsorption as well. It is true theoretically, but again, the studies have not shown any difference of outcomes. So take it with a pinch of salt that this membrane is better. I suggest whatever we have, the cheaper we have, we can use it. So this, in terms of the lifespan of patients, the lifespan of the different circuits, CVVH as versus CVHD and CVH versus CVHDF, the main thing which we can see is that the lifespan is better if we combine the dialysis as well as diafiltration. So for all these reasons, the diafiltration is now taken over and being equivalent. Now coming to the meat of the presentation, took me a long time to get here, is the dose of CRRT that we should prescribe. So in theory, the dose refers to the volume of blood that we would prescribe, and it is calculated by the effluent rate. That is, how much of fluid are we removing in terms of ml per kilogram per hour, and is the ultrafiltration rate for the hemofiltration, and the sum of the ultrafiltration rate and the dialysis rate for continuous venous hemodiafiltration. So if you have one modality alone, as filtration alone, the dose is the ultrafiltration rate, whereas for the combined modality, the veno-venous hemodiafiltration, the dose is actually the sum of the ultrafiltration rate and the dialysis rate. So this will become clearer when I show the dialysis orders at the right. Now, the next few slides are showing the different studies that compare the different effluent doses. Which I said, this is the first study which showed that using a higher dose was better for renal function recovery. But now the later studies are at the bottom of this table. The 18th study and the renal study showing that the two groups were equivalent. This is where I said that the SLED and the CRRT are considered equivalent in the study, in the 18th study, in which they group them together as compared to the CVHDF alone. This is the way the data is swung in terms of the target. Now, so coming to the KDO guideline, they say that we recommend delivering an effluent volume of 20 to 25 ml per kilogram per hour. So the important thing is, in order to get a delivered dose of 20 to 25 ml per kilogram per hour, we need to prescribe in the range of 25 to 30 ml per kilogram per hour. This is for two reasons. One is we might have some interruptions in the CRRT. Two, the volume of distribution increases because the patient is volume overloaded. Therefore, we are advised to start with a slightly higher dose of prescribed CRRT so that we'll give sufficient delivered dose of CRRT. I hope this part is clear. So this is a repetition of what I said. No benefits of doses more than 25 ml per kilogram. Now, for many reasons, the delivered dose is less than the prescribed dose. Patient-related factors, especially the increased volume of distribution of urea, and treatment-related factors in which there's recirculation, malfunction of the axis, there's the clotting, pre-dilution versus post-dilution, the ratio of this QB versus QD in hemodialysis, and most important being downtime. So so to get 25 prescribe 30, so about at least 5 ml per kilogram per hour prescription should be higher. Between 5 and 10 is probably safe. So to repeat that part, 25 to 30 ml per kg to compensate for circuit downtime, higher volume of distribution. And if the patient is hyperkalemic or has severe acidosis, we may need to give a higher dose to start with, and we can come down on the volume, come down on the dose after some time. The higher doses given in COVID-19, just to sidetrack a bit, in COVID-19, the recommendation is to give higher doses pre-dilution to prevent circuit clotting. So we use CRRT for these patients. But we can give a shorter duration of therapy. That's actually a different discussion. So I'm not saying it more, except to say that we can give it shorter, but we need to give it pre-dilution and higher doses in COVID-19. So when I'll show the COVID prescription, what we are following. Then dynamic dosing is also possible if you have a patient who's got hyperkalemia, severe metabolic acidosis, and hypercatabolic state. We can actually increase or decrease the doses, giving a minimum of 20, 25, but increasing it as a patient's requirement maybe. So the other thing is this allows us flexibility. So despite us knowing that there's no overall advantage of giving more than 20 or 25, we need to keep in mind the patient's clinical state and give a little higher dose if the patient has got any of these that we discussed. So a few definitions before we go forward. Low dose is considered when we give less than 20 ml. The standard dose is when we give 20 to 25 or 20 to 30. High dose CRRT is when we give 30 ml or 35 to 40, depending on which reference we use. There's something called high volume hemofiltration where more than 35 is given. Very high volume when we give more than 45 ml. And there's something called a pulse high volume when we give give it short duration, very high volume, and after that we come back to conventional volume. So for the general knowledge, I just put these definitions over there. So now coming to the nitty-gritty of what we actually do. Let's take an example of a patient who weighs 60 kilos. For example, if it's a patient, we looked at the first patient we looked at in the case, let's assume his weight is 60 kilos. The dose we need to give will be 60 to 25. Let's stick to 25. And if we give CVH, the replacement fluid volume will be 60 times 25, that's 1500 ml. So if we use CVVH alone, we can give either pre or post pump, and we give 60 ml times 25 ml, that's 1500 ml per hour. We commonly, as I said, we use CVHDF, and that I said was divided between the replacement fluid volume and the dialysate volume. So half of the dose is given as replacement fluid, the 70 ml per hour, and half is given as the dialysate, 70 ml per hour. So the sum of the two is a dose offered to the patient. So they write a prescription. The replacement fluid is given as 70 ml per hour, and the dialysate fluid is given as 750 ml per hour. I hope this theoretical part is clear. Now there's a concept of filtration fraction. The filtration fraction is a important concept if we want to remove large amounts of fluid. So filtration fraction refers to the fraction of the plasma that's removed from the volume of plasma that's removed from the blood during hemofiltration, and that is the volume removed by ultrafiltration rate. So they say that the ideal filtration fraction for a patient with a hematocrit of 0.3, that's about 30%, or a HB of 10, is about 0.25. If you use a higher filtration fraction than this, the hemoconcentration can cause filter failure. So bear with me as we do the mathematical construct a bit. There are a few simple formulae used and some little more complicated formulae used. The simplest formula is to divide the ultrafiltration rate by the blood flow rate. A better one would be ultrafiltration rate divided by the blood pump rate times 1 minus hematocrit plus the pre-dilution replacement fluid rate. So just ignore this, the thing. I just come to the next slide to show what the actual value is. So we substitute these values. The filtration fraction, when we substitute, we get the value of 1000 ml. I can give these slides for those who are interested and who are mathematically more inclined. I did this calculation myself, so I know this calculation part is right. This is just to give us the maximum ultrafiltration we can do. For a 60 ml, 60 kg man, the maximum ultrafiltration we can do is 1000 ml per hour. So we cannot remove more than a liter per hour for the 60 kilogram man. If the replacement fluid is 750 ml per minute, 750 ml, as we discussed in the previous example, we cannot remove more than 250 ml per hour extra as per net ultrafiltration. So only 1000 ml per hour we can remove as per as this formula is concerned. And therefore, if you want to, and if the replacement fluid volume is 750, we cannot remove more than 250 ml per hour extra as per as, otherwise the filter will clog. But all this is only theoretical consideration, because in practice we start with about nil or 100 ml per hour because these patients are usually quite dynamically compromised, and then we trend as much as possible based on blood flow rates and based on the blood pressure. If we do need to remove more fluid, that is the patient's fluid overloaded and you want to avoid ventilation, for example, then we can increase the filtration fraction by increasing the blood flow rate, which is the most important determinant for the amount of ultrafiltration we can do. I hope this concentration, this calculation, or the principle behind the calculation is clear to everyone. Now coming to anticoagulation with citrate. The citrate chelates the calcium and makes it unavailable for the coagulation cascade, and therefore we have a target of ionized calcium, target of serum calcium that we give. and then the citrate is metabolized into carbon dioxide and water, and reversible of citrate, when we give back the blood, we give IV calcium infusion. So the mechanism of action is that you actually cause the pre-citrate calcium, the volume reduces by causing it to complex with the citrate, and therefore we are able to stop the blood from clotting in the circuit. Now, there are three types of citrate that's available. Either we can give the citrate separately, or we've got 4% or 2%. Or, as I was discussing just before the session started, there is a new preparation which Baxter Gambro have come up with called RegioCit, which contains 18 millimoles of citrate, which is in the per liter of citrate in the replacement fluid. So RegioCit is actually a replacement fluid which has got calcium in it, and therefore we don't need to have a separate line giving citrate in it. So we don't need to give separate line giving citrate to anticoagulate the circuit. And this has been custom made, and therefore they say it's better, doesn't cause hypernatremia, doesn't have cause metabolic acidosis. I think the easiest thing is the ease of use. It's its biggest advantage than anything else. Now, these patients have been monitored closely, at least 6 to 12 hours the first day or two, and thereafter every day, and depending on at least once a day, we will check their labs because they're in the ICU. The complications of renal anticoagulation with citrate are the complications that we would expect of electrolyte imbalance and acid-base balance. This is what we do. We add the citrate to the access line in this, and the significant amount of the citrate and the calcium bound are lost in the effluent. The dialysate should be citrate free. So there are two types of, essentially, although there are few more, there are essentially two types of dialysate fluid. One which is without calcium, and one which is with calcium. The one with calcium used to be called Prismosol, and the one without calcium used to be called Prismocal, where the O is actually meaning zero. So Prism zero calcium, they call it Prismocal. Of course, like I said, now they've got different names, and depending on the country, they have slightly different compositions, and it's returned back to the body. And I said, we give back the IV calcium, separate IV infusion. So ionized calcium level for when it is low, less than 0.25 millimoles or less than 1 milligram per deciliter, there is no clotting, and this is a dose dependent. Therefore, rather than calculate every time, it's better we have a nomogram and we show the value that we follow. These are our dialysis order sheets. So I hope this will be helpful. So most of the time, our prescription is continuous venous hemodiafiltration, and the blood flow rate is 100 to 150 ml. This is using RegioCit. If you remember, RegioCit is the pre-pump replacement fluid which contains the citrate, which is used for regional anticoagulation. The regional anticoagulation, citrate are the words that they use for calling it RegioCit. And the post dilution, the dialysate fluid, exactly the same as the RegioCit, but without the citrate, is something called bivozil. So this is the replacement fluid, or the dialysate fluid. It's exactly the same, and this is, as I said, it's dialysate dose minus the RegioCit dose. The RegioCit dose we have already giving pre-pump, and therefore that 25 ml per kilogram per hour minus 600. Now, where does 600 come from? 600 to start with is the nomogram, which this is the calculation which we did. The citrate twice the amount of blood flow rate we must give, divided by the constant of citrate in the RegioCit. We came up with this figure of 600 ml. This is entirely our calculation. We have not validated it or published it, so we're not very certain about its true validity, but it seems to work. And this is what we subtract from the total dose that we have. 25 ml per kilogram, as we said, is the total dose. minus the 600, and this value will change, and therefore we need to adjust the dialysate fluid value as the with time depending on the nomogram. Now these are the different fluids that are available currently. The Prismosol, as I said, without any with is the one which came out initially, and the Prismocal, which has got zero calcium, and the Regiosit, which has also got zero calcium. There are minor differences between the Prismocal and the Regiosit, and the bifocil is the replacement fluid, which is the replacement fluid nearly identical to the regiosit but doesn't have citrate. The ions are a little differently maintained to maintain the same tonicity. So the citrate dose that we give is based on the redialysate blood plump time to concentration divided by the QB. So this is how we got the concentration starting dose of 2 millimoles per hour, and then we calculate. For those who are interested, you look at the slide. We rounded up to 600, although 666, the number of the antichrist, is probably closer to the truth, and we give it pre-filter replacement fluid. So the citrate dose which we give is 25 ml into by 1000 ml per hour. Regiosit is 600, and the bifocil is 400. This is to start with, and then we change based on the dosage of the pre-filter regiosit based on the level of anticoagulation, which will come up in the next part, which is the nomogram. So the regiosit, if we're using this, the anticoagulation orders, we check the ionized calcium, and then we prime the circuit, mix calcium gluconate, and give the infusion. Start with 30 ml per hour. Start the regiosit infusion. 600 ml per hour must be run using free plump pump. We check the patient and the circuit ionized calcium an hour and a half later, and we based on patient's fluid, we adjust the patient's fluid removal to compensate for the small amounts of calcium that's infused. And this is the way we target the regiosit infusion. We'll targeting the ionized calcium of this range, we increase or decrease the regiosit infusion and get the target ionized circuit calcium. And this is the other part of the same protocol, which we adjust the regiosit infusion, which I said, and the calcium infusion is according to the patient's ionized calcium according to this nomogram. If it's low, we stop. If it's high, we increase and decrease as based on the algorithm. And this is the monitoring sheet we use. This is for run. We each one sheet for 12 hours. We write the time and write the blood flow, the volume of regiosit, calcium, patient, ionized calcium, replacement fluid dose, amount of fluid removed, and addition, anything extra we need to write it all. There's a downtime. And this is the regular fluid order in which we give replacement fluid with citrate, which is given by a citrate infusion using the AACD formula. And again, the rest of the algorithm is roughly the same as we discussed earlier. The complications of renal anticoagulation I've already discussed, so I won't mention them again. We modified for the COVID patients. We used a higher blood flow, and we gave bifocil at a higher level to give a higher dose. We gave 35 ml per kilogram minus the initial 600. So we gave a higher dialysis dose for these patients. The last part is just a theoretical one, mostly that we've only used it in a couple of patients, using ECMO circuit. The extracorporeal membrane oxygenation for patients who've got very bad lung disease. The blood flow rates of these patients are usually at least 2 liters per minute, the blood flow rates, and usually around 2.8 liters per minute. The circuit connections are similar, but you cannot connect directly because the pressures are much higher than those required for CRRT. So as you can imagine, our blood flow rate is 100 or 150, and here you've got 2.8 liters. There are two ways of connecting. Either you can connect them in parallel or in series. And so I just show the pictures that again, These are pictures that we've found and we've used. This is the blood which is flowing from the patient, and there's a pump. And the first option is to divert the part of the fluid here itself and offer CRRT in parallel, and the dialyzed or the renal replacement therapy done fluid returns, and that goes into the membrane oxygenator and goes back to the patient. So that's one option. The other option is to connect them in series, in which the blood goes to the centrifugal pump, goes to the oxygenator. As it's going back to the patient, you take some of the blood out. This is 2.8 liters per minute, and this is 100 ml per minute, and you take the blood into the circuit for giving them the extracorporeal renal replacement therapy. There is some, because it's going back into this volume, is going back into the oxygenator, there's some amount of recirculation, but then 2.8 liters we are doing membrane oxygenation for. This is about a 100 ml per minute. So it's a very, very small, I think, small difference. Of course, just one last word about energy and nutrition. Nutrition cannot be forgotten. Any patient in the ICU, especially patients who are on extracorporeal therapy, where they need extra energy and protein supplementation. So, to conclude the long session, in patients of multi-organ failure and AKI with septic shock, they're critically ill, and we play a very, very important role in providing the optimum renal replacement therapy. The jury is out regarding which is better, CRRT versus lead. I think because lead is far cheaper, it should be the first choice. But CRRT has this place where we think the patient is really hemodynamically compromised and we can't even offer lead, although that has not been studied. Can we give CRRT in somebody who is not tolerating lead? Has not been studied, but intuitively everybody seems to think so. And we've talked about citrate regional anticoagulation, and also talked about using citrate containing prefilter replacement fluid as Regocit, and we talked about the dosing, and lastly we talked about how it can be combined with ECMO fluids. ECMO circuits. Thank you very much for your patient listening, and I'm sorry it was a very long presentation, and I'm happy to try to answer some questions.
Thank you very much, Dr. Santosh. It's always a pleasure to hear you talk, and it is quite intriguing for most of us here who live in this part of the world where we don't have much tangible exposure to CRRT and mostly are using IHD. So we have a couple of questions in the chat box. The first one from Chima Onyenuche, and the question is, please, which value of the blood warmer is best, 37, 39, or 41 Celsius?
Actually, I'm not very certain as to whether there's whether they have studied any studied. In general, we've been using, as well as in Toronto, they were using 39. I think is because that I don't think it's been really systematically studied to show whether it's anything is better, or in terms of better hemodynamic stability or so on, like in other fluids. I'm not certain if it's been studied, but in general, 39 is more commonly used worldwide. But I must confess, I didn't think of the question or read about that. I don't know the exact answer.
Thank you very much. And we have another question from Dr. John Gumbi concerning the risk of developing DDS on CRRT.
I'm sorry, risk of what?
Risk of dialysis disequilibrium on CRRT.
Right. So I haven't read about any instance of dialysis disequilibrium. In general, it's not a very common thing that happens in acute kidney injuries, because the brain has not yet had time to get loaded with toxins, osmolytes. The word is not toxins, osmolytes. So I don't think this occurs very often in acute kidney injury.
Thank you again. And then we have a question from Dr. Ben Lomateo. And he says that the experience with citrate is not much in most ICUs. So what would your take be on that?
Yeah, it's true. For the first few years, I must say that we did not have citrate in India. Citrate-based fluid in India, anticoagulation was not possible in India until 2009, not 19, 18 Jan or 19 Jan. I think it was 18 Jan. Yeah, 2 years before COVID hit us. Until then, it was not available. So even though we wanted to give, we couldn't. So I think for us as well, our experience has only been very, very recent in comparison to our early experience with heparin. So we've also used heparin earlier. Yeah. I just want to add one more thing. There is at least one paper in which they've used the heparin-based fluid and did regional anticoagulation, and they found that it was possible. So, so it's been done. I can send the reference. I think it was American Journal of Kidney Disease had a had a letter to the editor kind of thing in which they actually used the fluid. I made a presentation of about CRRT once to a group of nephrologists, and to cut costs, one hospital they were giving them. They were not buying the citrate-based fluid because it's expensive, and they were using citrate in them using the heparin fluid itself. The difference is that contains calcium. So despite that, uh, they were able to do it. So there is at least one colleague of mine who's used it deliberately or albeit accidentally. That is his hospital had stocked the wrong kind of fluid and they were using it. And there's at least one published literature in which they have done it safely, and you can use it uh, with the regular fluid which contain calcium and to cut down costs. So to answer a long question, yes, we can use citrate in the circuit with the calcium-based containing fluid, although theoretically we shouldn't be doing
Thank you once again. And we have the same question from two people asking about SLED as an equivalent to CRRT, especially in a setting like ours, where we have very sick patients who need to be moved around more often than not. And, if it's possible to do on the same machine that we have in this setup again, as far as SLED is concerned. So what would your take be on that?
I completely agree about sled. I'm a sled enthusiast. When sled came to India, I was a postgraduate and I made a presentation in which the question was asked: is sled the default RRT for the ICU? Sled is a more recent one than CRRT. So the sled parameters, if we are able to give it, definitely is a very, very useful therapy. And with machines like the 5008S machine, you can lower the dialysis volume to as low as 100 ml per minute. Because very volume, if we lower the dialysis volume to 100 ml per minute, we can really manage to offer renal replacement therapy for a lot of people. Um, if you all if you all haven't had a session on sled, I'm happy to do one. I've actually done one although it was not very recent on in a large meeting in which I think sled is actually very, very good, and given the constraints of finances that our countries face, I think sled is a very, very uh, good treatment and should be the default RRT of choice in the ICU for hemodynamic compromised patients.
Dr. Lloyd has a question. Dr. Lloyd, can you unmute yourself?
Yeah, so no, I think one question that was there was whether you can use the same machine for SLED and hemodialysis.
Yeah,
So
the same machine can be used. I think the software can be programmed to bring down the dialysate volume to about 100, 200 or 300. In 300, at least most machines can lower the dialysate volume. At least the machines that we have, you can lower the volume to 300 rather than the conventional 500 or 800. So the Western world, the sled that most places offer is 300 ml of dialysate flow. So it's okay, we can offer it. We can offer a sled on the same machine as the intermittent hemodialysis, but we can't get 100 ml per minute dialysate flow rates. But all the
Yes.
literature that's available is with 300 ml, so we can actually use a conventional machine for it.
Yeah. So there is one. You see the dialysate flow. Conventionally, as Dr. Santosh mentioned, is between 800 and 300. So usually you don't go beyond 300, below 300. But actually, if you really want, I mean, if a company is innovative, they can actually change that dialysate pump to what's called as a gear pump with a lower flow. So the dialysate pump is a gear pump. That means it is just a sort of it ensures the flow, a regulated flow. So when you use now, it does not go beyond 300 in their conventional intermittent hemodialysis machine. But if you change that gear pump to, I mean, come to a lower flow, it is very possible to get it up to 100. And not only that you use it for sled, but you can also use it in children. For the dialysis flow can be modulated to use in smaller children. And at the same time, you see the blood pump it's actually a peristaltic pump. So you can actually modulate the blood pump that actually goes up from like maybe even from 60 to 400, and the dialysate pump that can go up from anywhere from 100 to 300. And you can use a sled, and for pediatric dialysis, if you modulate the machine, and it's not that difficult, and it doesn't change the cost. Although the company is marketed at a very high price, it can be really made very cheap just by modulating the two pumps. But unfortunately, in India, we don't manufacture that. We have to import it. That's the only issue that is there. Yeah.
And with tongue in cheek, I want to add this thing of that the Fresenius had a 4008 S series machine called the ARRT Plus, which they did not market in North America or Europe, despite it being manufactured in Germany. They were marketing it in India, and we were using it a lot, and we could lower the dialysate flow rate to 200. But they killed that brand, and they didn't market in North America because they wanted the 5008 S to catch on.
Yes. That's there. I mean, that's very well. Yeah. The other thing is, one quick question is the systemic ionized calcium and post-filter ionized calcium. Now, measuring calcium is expensive. So what is your protocol for that?
So I'll just share that slide again.
Yeah.
So this is our algorithm for the calcium infusion, and this is Dr. Lloyd said this is exactly what we used to. This is what we used to use in Mount Sinai Hospital in Toronto. It's just borrowed, and only millimoles have been converted to milligrams. This is exactly what we used to use. And the nomogram we follow, we measure, and we change the rates.
Okay. Now, the calcium measurement, how frequently do you check, or like you go according to nomogram only? Once you measure first time and then just go according to nomogram?
So we check every 6 hours.
6 hours. 6 hours. Yes. Thank you. Got it. Thank you.
And we have one more question from Dr. Lomateo again, and he's asking, why is it called veno-venous?
Yeah. So I think that is the line, the source of blood which is used to supply the blood into the extracorporeal circuit. As the first CRRT to come was a CAVH, in which they put the line, the blood pump line into the artery and the femoral artery, and whatever the pressure the femoral artery was able to generate was what pushed the blood without a pump. This is the pre-pump time, and they used that went into the circuit at the lower rate, and hemofiltration was done in these patients, CAVH. And obviously, when people are hemodynamic compromised, and that's the group that we are giving CRRT to, we know that the arterial pressures will be often insufficient, and therefore they change it into a veno-venous hemofiltration, which you can actually pull the blood out using the pump like you do for conventional hemodialysis, and that's why it becomes CVVH.
Most of the questions we are getting this evening are on sleds, so we will have to request you to come back to us very soon and give us a talk on that as well.
God willing, happy to do so.
Yeah, because that is something that is practical and it can be done here. CRT is very expensive, and yeah, you need the machine for it, and it can only be done in the big city like Nairobi, whereas it's not very feasible in the other parts. Yes, there's no more questions, and it must be very late for you, Santosh. Thank you very much. Actually, it was a wonderful session. Extremely grateful for the session, and it is really detailed a lot of CRT, and I think good exposure to the whole topic of CRT. Everything very comprehensively covered. Extremely grateful. Thank you very much. Thank you.
Not at all. The pleasure and the privilege is all mine. I'm always happy to interact with my friends across the ocean, and I'm like I really enjoy it, and enjoy meeting you all. Hope to meet you all in person at some conferences when travel becomes easier. And as always, the slides are available for anyone. What we say they are copyrighted is what we use in the term we use in India. You have the right to copy them for your personal use, or if you want to teach them. So that's what we call copyright in India, the right to copy. Please feel free.
Thank you so much, Dr. Santosh.
Thank you. Thank you, Santosh. Thank you very much. Thank you.